Our next speaker is Ronnie Stein, and she's going to educate us on interstitial keratitis. What is the best treatment?
Thank you, Sophie, and thank you to the organizers for inviting me to join the subspecialty day, even when I was a little bit difficult to find this year. So I am going to be talking about interstitial keratitis. I have no financial disclosures, an overview of the next 8 minutes, a little bit of the basics. What is interstitial keratitis? What are the clinical findings? How do we diagnose? What are the etiologies associated and differential diagnosis? And finally, the treatment. What are our goals and how do we get there? So the basics. Interstitial keratitis is a bit of a bucket diagnosis. It is non-ulcerative, non-suppurative inflammation of the corneal stroma. It's often associated with neovascularization, but does not have to be. It is often unilateral, except that actually in syphilis, which is one of the most common causes, it's usually bilateral. The immunologic response within the cornea can be antigen-antibody complex deposition, it can be complement-mediated, or it can be delayed type hypersensitivity. So really any inflammation that's going on in the corneal stroma that's not involving epithelium or endothelium is essentially interstitial keratitis. There are two clinical phases. There's an active phase with the active inflammation. You often see a ground glass appearance of the cornea. Again, neovascularization tends to come in from the periphery. That's where the vessels are. Intrastromal hemorrhage can occur when the inflammation is active. Patients are often very symptomatic. This is painful, lots of tearing, photophobia, blepharospasm. In the later phase, many patients will develop persistent corneal opacity. There's often associated stromal thinning. In most cases, the neovascularization does regress to leave you with ghost vessels, and that's usually a painless phase for the patients. So diagnosis. This is primarily a clinical diagnosis based on what is seen in the patient. Again, the immune response in the corneal stroma can have multiple causes. It can be bacterial, viral, parasitic, or immune-mediated. I'll break that down into some more categories. I do not have time to go over every one of these, but we will highlight just a couple briefly here. Again, syphilis historically has been the most common cause of interstitial keratitis. Congenital syphilis, often bilateral, although not necessarily presenting at the same time. So the second eye can be affected months or even years later. Congenital syphilis usually shows up at first in younger folks, but of course, these diseases don't always follow the rules. Acquired syphilis in general does present later in life, and it usually does present in conjunction with an anterior uveitis as well, if you have the interstitial keratitis. Cogan's disease also can't go a talk on interstitial keratitis without bringing up Cogan's disease. It is a systemic vasculitis. There's interstitial keratitis as well as vestibulo-auditory symptoms. To be clear, syphilis also often has auditory, especially congenital syphilis has auditory findings as well. Really the hallmark with Cogan's is that there are vestibular findings as well. If you suspect Cogan's disease, involve rheumatology, ENT, these are systemic conditions that need to be treated quickly. And then also to mention viral, at least in my practice, again, it's important where you practice. Viral etiology is the most common that I see for interstitial keratitis, and it is most commonly herpes simplex. So for diagnosis, you really do need to do a comprehensive medical and ocular history on these folks, a full review of systems. That turning on the lights thing is useful. Asking about any recent exposures, insect or animal bites, previous infections, travel history, trauma, and medication use. On physical examination, the slit lamp examination, the things that you're primarily looking at or looking for or expecting to see with interstitial keratitis include conjunctival injection, corneal haze, which can follow any pattern really, stromal infiltration, but again, without significant necrosis, and no ulceration, and then stromal neovascularization or ghost vessels. And those vessels can sometimes leak lipid, and so there can be a layer of lipid within the inflammation. Some laboratory testing is often indicated unless you have a clear idea of what's going on. It's useful to help use your physical exam, use your history to help guide what laboratory testing you are going to do for each particular patient. And again, back to this very extensive list of potential issues that can be associated. And then you also have to differentiate from other things that can be found within the cornea that are not interstitial keratitis. Probably the most common would be ulcerative keratitis, which can again be infectious or immune mediated, but has the ulceration, the epithelial involvement, and the necrosis. Sometimes endothelial disease can lead to secondary corneal haze, which can be tricky and look like it's an interstitial keratitis. There can be corneal dystrophies or traumatic corneal scarring that can be confused for IK. And finally, treatment. So really our treatment goals, number one, is identifying that underlying pathology. Because again, although we call interstitial keratitis all of these potential things that lead to the clinical finding of interstitial keratitis, each of those entities does need to be treated specifically. So once that's done, then we can worry about controlling the local inflammation, and of course, optimizing visual function is our third goal. In terms of identifying the underlying pathology, again, careful history and physical, appropriate ancillary testing, treating any specific infectious etiology first, and getting help from friends in rheumatology, ENT, or infectious disease as needed. Controlling the local inflammation has definitely been shown to reduce the severity and duration of the painful acute episode of IK. It also has been shown to improve long-term visual acuity and to reduce scarring. The mainstay here really is topical corticosteroids, but in many of these cases, these patients really need to be followed very closely in terms of how much steroid you're using. In some cases, oral steroid is needed as well, and all of these steroid medications should be tapered very slowly and under direct observation to make sure that there's no recurrence of the inflammation. And along with all of this treatment, monitoring intraocular pressure closely. And rarely there can be more severe sequelae of interstitial keratitis. Acute perforation is rare, but if it occurs, obviously it needs to be treated surgically. And sometimes the long-term sequelae of corneal scarring or thinning also needs to be treated surgically in order to optimize the patient's long-term vision. So this is just a timeline of a patient in their acute phase, chronic phase, and then post-surgery. And so final thoughts, what's the best treatment for interstitial keratitis? As with so many of these inflammatory conditions, it's the right treatment for your patient. Thank you.